Great. Wow. Well, I am totally humbled to be here and amazed that we are in person, and hope everybody does stay safe and stay healthy. This is just seeing the number of people that I have had the privilege of talking to help inspire these papers is incredible. You all work every day so profoundly, and I was just having a conversation with I don't see her, Anne over there. And we were talking about the role of the commissioner and the importance of trying to manage what I call the entropic forces, which is like the natural tendency, it's a physics principle, the natural tendency for things to devolve. And the role of the commissioner is to use their own personal strengths and energy to keep things going on a good path to help better the world of mental health. And so kudos to all of you, and just remember to nourish yourselves so that you don't expend more energy than the forces that are fighting against you. So, all right, so what we're gonna talk about today is this year's theme, From Crisis to Care. Yay, 988, hurrah, like amazing, 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 right? But one of the daunting tasks that Brian gives me for the last, I think now, 6 years is to come up with, well, what's next? And so I'm always using these papers as a way to take stock of the amazing accomplishments, but also to think about how do we push the system forward, right? We've got 988. But the challenge, as anyone knows who's worked in crisis care, and I spend a lot of my professional time in psychiatric emergency departments to this day, is what comes after the crisis? And is the system going to be ready to respond, as we said last year, and be available to provide the care that's necessary? And then when I unveiled the title to Brian this year, and we had a little text exchange, we talked about the idea is the metaphor, because we have been in crisis as a system and as a people with COVID-19 and everything else. And we need to, again, care for ourselves and care for the system so that the very individuals like Rowan can get the care that they need. So that's this year's theme, and you will see numbers of papers along these lines, and somehow my slide is not moving forward. Sorry. Did something happen? Tech support. What am I doing wrong? I can say next slide. There's an on and off switch. Amazing. Okay, good. See, you would think I'm good at this stuff. All right. So you guys know me. You already heard about me. Just want to say I have no conflicts of interest to disclose, and delighted to be here, and that the work of this is supported through SAMHSA and through NASMHPD. I couldn't do the work of writing these papers without my research assistant, Elizabeth Sinclair Hank, who is literally sending me emails to this minute, just a minute ago, about another paper that we've gotten through and editing. And Neely this year took the helm. Where's Neely? Big shout out to Neely from NASMHPD, who's been our lead, as I call her, the ATC, air traffic control, and facilitator for the papers, and of course the entire NASMHPD team, and so many others who've informed the work. So let me just go back a little bit in the journey. Brian alluded to it, but this all started with Linda Zeller, then Commissioner of Michigan, asking me to help Brian with a paper that we titled Beyond Beds, because at the time everybody was saying, why did those darn state hospitals downsize? We need more beds, more beds, more beds. And the idea was to think about, well, is that really the answer? What do we know scientifically about how many beds a system needs to serve the people? Well, what we learned from that year and from all of our collective experience is that you can't measure it without knowing what you have in your continuum. And you really need to build out your continuum as a way to offset the needs for beds. And of course, like any chronic health condition, you might need hospitalization. Hospitalization is not a bad thing. It's obviously something you want to avoid when you can, but it's necessary when it's necessary. And yet you don't want that to be your be-all, end-all for all the services that people need. So we came up with this theme of the vital role of a full continuum of psychiatric care. We came up with 10 prescient recommendations, many of which are the themes that we repeat over and over and over again, and I'm going to talk about today. We did a series after that, Bolder Goals, Better Results, 7 Breakthrough Strategies. I would just encourage you to look at these old papers because they're sort of oldies but goodies and give you some nuggets. We looked at things around the world, at what other countries have done. There's a section in there even about how countries respond to disasters and build back better behavioral health systems after disasters. And that was pre-COVID-19. Then, of course, we get hit with COVID-19, which just continues. And at the same time, we're talking about crisis services. It's like that came out in February, COVID hit in March. COVID was hitting, but it was unbelievable, the timing that led us to this moment where we were building out crisis services, trying to respond to COVID-19 and mental health. So this is the journey we've been on. And so now we've got 988. The suicide and crisis lifeline begins. I, like many of you, have been responding to media calls and questions about how 988 is going to work. I've been asked, what happens when you call the number? There's blogs out there about that 20% that may get a bad response instead of a good response. I don't know if you've seen those, but certainly the reporters that have been talking to me have been asking me about that. So we have a lot of things still to build in 988, for sure, as it rolls out and as it serves this amazing, as an amazing resource. But none of the catalysts that drove us to this moment have gone away. We still have high suicide rates, waiting to hear the data on what that will look like with the impact of COVID. Workforce, we've got CCBHCs, we've got an opioid crisis, we've got jail diversion and law enforcement needs, we've got prevention coming in with children and adolescent services, we've got litigation coming at us from all different directions. So lots of things, both good and challenging, that are catalysts for what we need to think about as the systems move forward. So this year's paper really focuses on what I think, listening to the commissioners' meetings that I'm on, and you guys see us on Zoom, and we wave and say hello, and I listen and hear what is on people's minds, talk to colleagues around the country and internationally. And really, I think there are 7 themes that as commissioners, you need to think about and think about very carefully as you move, while you're building up your crisis system, to think about what comes next after the crisis. What is the care that is going to be received and available to the tsunami of people who are going to have those needs? And so what we need, of course, I don't know if these are really in order, but I suppose they are in order. We need a strong behavioral health workforce, and I'll talk a little bit about each one. We need, in the generic and in the Medicaid sense, effective home and community-based services. And I say generic because I want you to think beyond just Medicaid. We need services for people like us who might need nurturing and supports as we roll forward to try and push change. Supports for our children. We need timely access to care. And yes, I know Joe's in the room and he's going to say, we got the answer, CCBHCs. They are part of the answer for sure, but we need timely access to care. I'll talk about that. We need engagement and strategies to foster retention in care. It is not enough to get people to walk in the door. The dropout rates, I'll talk about in a moment, are astounding. And there are things we can do to improve and look at data that measures retention in care. We need strategies for routinizing, cool, we all know Zoom now, routinizing and developing effective technology. More to say about that in a moment. We need to build out the old partnerships better. We need to build new partnerships, and we need to improve wherever we can, because we cannot do this alone. And we need not just sustainable services, but we need expandable services, because the needs, if you look at any of the forecasting, the needs are not going to go away. They're only going to get worse. Okay, so I'm going to walk you through each of these a little bit in kind. Strong behavioral workforce. I don't have to tell you this. This is the huge theme that comes up in every meeting. Now, there's a lot of things going on that's exciting about workforce developments, and I'll mention that. I only have a limited time. You'll get to read about this much more in much more detail, and I usually heavily reference these papers to give you lots of resources beyond just my words and the words of our authors. We recommend that everything have links so you can find them for yourselves. But what's really interesting is this whole interplay of behavioral health and workforce, okay? There was a report in Lancet that showed that the predictions of anxiety and depression related to COVID-19 are going to cause a 25% increase in disability-adjusted life years. So if we can fix behavioral health and get people treated, we actually could help the workforce, because a lot of the workforce is out. We know that more people are taking sick days for mental health reasons than they are for even physical reasons these days. So it's a very intertwined issue. We can say we want more workers, we want more workers. We need more services to help support the workers and rebuild the workers. We know that from the Household Pulse Survey that the CDC and the US Census Bureau have been putting out, and lots of other data, that the BIPOC population, where we're trying to grow diversity in the workforce, the BIPOC population is disproportionately impacted with anxiety and depression. So again, this interplay of behavioral health and the workforce. We know that parents miss work often due to their own children's behavioral health needs. So we have to build out a better children's behavioral health system to support the parents who we want to be working in whatever the jobs are that you want people to be working in. Mental Health America reported that 50% of people needing services are not receiving them. That is not going to help our workforce. So in the behavioral health space, HRSA has done a lot of work in this, SAMHSA as well. One report that was done pre-COVID just showed these projections of serious shortages on the horizon, and this was pre-COVID. National Council for Mental Well-Being and HMA put a report out that that surveyed providers that showed 97% were reporting challenges recruiting and retaining new employees. And of course, you're all calling in reinforcements. It was just today I heard another state, many states, calling in the National Guard to support the work of their institutions and other places. I don't know about you, but that takes a lot too, because I know when we had some National Guard supports, there was a lot of work that needed to be done around how they were going to help the behavioral health population. So lots to think about along that. So what do we do about the workforce? There are many, many strategies, and we're culling a list together. If you look, the wealth of resources about workforce development are astounding, but they're scattered. One group, I thought, Beck, Spetz, and Pittman really talk about in health affairs, this idea of thinking along 4 dimensions. Production, growing a workforce from childhood and beyond. Beyond me just saying to my kids, you might want to go into. I do have one daughter who's doing direct care, which I'm really proud of. Then the distribution. Where are they going? How are they distributed across rural and urban areas? Then how do we build the workforce resilience? You know, I went and did a site visit a bit ago, and they have this whole space for their workers, this relaxation station, a massage chair, you know, really trying to build resilience within the workforce. How do you nurture your workforce so they want to remain in the workforce? And then also maximizing their potential, helping them to feel like they're important, like they matter, whether it's the janitor, the therapist, the psychiatrist, the administrator, the peer. Everybody has to realize that their role is critical, mission critical. And how do you maximize their potential so that they don't feel siloed, alone, and isolated? And I think if you think along those 4 dimensions, there's lots of great things to do. We also need more data about our workforce so that we understand diversity and penetration of different populations, matching the populations that are trying to be served. We need to reduce the regulatory barriers and burdens, and of course, improve collaborative care models in a way that provides meaning and still provides positive outcomes. So again, these are just a preview of what you're going to see when the paper comes out. And I hope we can have a little bit of time for discussion about this. How about effective home and community-based services? Well, again, I say this in the generic sense, which means literally not just for Medicaid recipients, but are there services that can be delivered in the home and be in the community? Think about what we know and what we've learned about 911. We now do stroke management, we do heart attack management, right? We do that in the home. What are we doing around behavioral health where we can actually start delivering the services, the treatment? So of course, we want to stabilize the condition, but really starting to develop the treatment. What about that person who's having a hard time because their psychosis and their voices are bad and they're having a first episode psychosis? Are we going to really be able to engage that person in the home to think about how medicine or other interventions, psychosocial interventions, might be helpful and really begin those conversations right from the get-go so they're not going from getting one message here to another message there to a third message there, and we can stay on point? So what I say is we need to take a page. I've always said this. As the more I was in adult forensic services, the more I said, if we could just copy paste what the kids are doing and everybody think family system. Everybody should be thinking stabilization in the home. Everybody should be thinking 30 days or 60 days of follow-up in the home. Why is it just kids that need it? The parents, if they're having an emotional crisis, they don't get that. They have to go to some other place. So we should be really thinking about home and community-based services across where you are fortunate enough to even have a family system, really, or your natural support system. How do you build those services in and de-traumatize? You heard what happened to Rowan. She got sent to a different place. Why do we have to send people to different places? Can we deliver services in the home? So out-of-hospital care is an area that I'm super fascinated by. I think it's really an important area that we have done major advances in medicine. We don't have parity in psychiatric care. We have to build that. Community-based services with strong evidence are also something that's necessary. Great published paper by Lisa Dixon and colleagues looking at assertive community treatment. We know the evidence works, but yet the implementation is so challenging. Why is it so challenging? What can we do to make it more usable in a way that gets that evidence-based practice to more people? What about a model like critical time intervention, which is a tried and true intervention I've been working with critical time intervention for years in a lot of my reentry work that I've done or court-related work, which is really, it was derived, it was developed to look as a transitional support in phases where you intensify services up front. You don't just send case managers to work with people and just say, good luck, rehab options. You say, this is our intentional methodology that we're going to work with people intense up front while you need those additional supports with lessened intensity as people transition into their natural supports. And Brooke Doyle, the commissioner in Massachusetts, will appreciate this. I used to run our forensic transition team, and there was always this worry about duplication of services. I came to believe that it's not about whether you're duplicating, it's whether you're smartly duplicating and doing those warm handoffs. Because sometimes you do need those additional supports with somebody who's got expertise of a particular area that can help with those warm handoffs. Supported housing and employment services, really an important area to build in, bake in, coordinated specialty care for first episode psychosis. We have people who are coming into the forensic system with first episode psychosis. They never had coordinated specialty care. Why are we missing those cases? And then access to medications, of course, of all sorts, to make sure that we're getting that and getting those to people in their community. Now, we know this HCBS final rule is kind of like out there and getting people a little bit anxious in certain ways. Olmstead, been around for a long time, nothing new. So how do we build these services now in the true home, the Medicaid version, the CMS version of home and community-based services, and think about care that's delivered in an integrated fashion, least restrictive, person-centered, youth-guided, family-driven. Those should be tenets for everyone, given the rights and needs of people that we're serving. So building out that care continuum so that when somebody calls 988 and they need those additional supports, or they're getting that preventive warm line, peer warm line, but they're not getting the supports they need in the community, then we have not done what we need to do to really tick and tie that continuum together. Timely access to care. I don't have to tell you, waits everywhere. is there any commissioner in the room that doesn't have at least one place in their system where people are waiting, whether it's a waiver service, whether it's ED boarding, whether it's waiting in jail to get into some kind of restoration service? There is no system that doesn't have waits, whether it's getting in to see a child psychiatrist or getting somebody who's got an IDD specialist. So what we see is these waits are creating these other challenges, and we keep doing a whack-a-mole trying to address a wait here and address the wait here, but then there's this other stuff happening, and then those people are getting their care in the ED, and they're not staying in care. So what is our strategy? Data collection to understand those waits, using the old performance improvement to increase efficiencies, identifying barriers to the next levels of care, again, CCBHCs as one remedy, but taking, again, a page from the CCBHC playbook where you're not a CCBHC, you can still look at the model of CCBHC, which is measuring time standards and access. Targeted funding, and then cooperation with partners who are frustrated and who believe the door is closed anyway, so then they find workarounds. They'll call the commissioner. They find workarounds. And then they're just not, it doesn't help. And I keep saying, the traffic laws are that you follow the flow of traffic and you will actually get there sooner, as opposed to trying to do cutting people off at the pass and doing workarounds, and everybody's dealing with contempt hearings. And I've had a couple of states I've worked in Michigan included, where we basically had a partnership with our judges and said, if you can slow down on the contempt hearings, we'll actually get people in sooner. And we did. And so, it's really trying to figure out what that means and helping engage partners. And then there's engagement. You heard Rowan speak about that. I mean, oh my gosh, this is just like psychiatry. Why I went into psychiatry, it was like treatment alliance. Like your therapeutic alliance with your patient was like what mattered. You spent time getting to know your patient, understanding them, listening to them, hearing them. But somehow treatment engagement is broken. NAMI put out an excellent report in 2015 about engagement as the next frontier. And I can tell you, you can have all the AOTs in the world. You can have court-ordered treatment. Even probation and parole are trying to figure out engagement strategies because they know you can lead a horse to water, but you can't make them drink. Like, you have to really engage on a human level. And how do you do that when we're all burnt out, fried, and trying to fight COVID? I mean, it is so hard. It is so hard. The work is so hard. And so we know that we're dealing with a lot of issues. We have people who have complex conditions, complex personalities. Hey, like I don't have a complex personality. We all have complex personalities. Brooke knows I have a really complex personality. Sorry, Brooke, I don't mean to pick on you. But, complex conditions leading to challenged engagement. I come from a family of physicians. One of them's a primary care physician. We talk about what happens in the waiting room in primary care in an FQHC. Somebody gets disruptive, you're out of care. We can't serve you. Well, our people have trauma histories. Our people are in distress. Our people are anxious. I know when I get anxious, I am not at my best. I get dysregulated, and I am a professional. So now you've got somebody who's in a one-down patient situation. They get complex. We don't like it. We don't know what to do with it. We don't know how to handle it. We get overwhelmed. I'm stressed. You think you're a stressed patient? I'm stressed too. I've had a bad day too. My kid's got behavioral health needs, and I could barely show up for work today, and now you're asking me for more. Engagement is so hard. So no surprise, we have dropouts. We have not only dropouts, but we have arrests out of care. I've been very interested. We're doing some research. I've done two little examples of this in 2 different states on a point-in-time study. The number of people that are arrested out of treatment settings and sent to the forensic setting is astounding. Inpatient psychiatric units, community adult foster care homes, emergency departments. People are getting arrested and kicked out of care more than they should be. Let's just say that, if they should ever be. And care in the EDs, then they go in, they can't get care, they don't have regular care, so they get their care in the EDs. Staff are burnt out because these are really challenging problems. So what do we do to intentionally build engagement? And again, you know, the job of the commissioner as the cheerleader, right, Anne? The cheerleader job is what we have to do all the time as leaders, and it's hard. So what do we think about? So this paper will say a lot more about engagement, but this is something that really needs to be looked at. What is your data showing you? Not just about who's accessing care, whether it's for opioid use disorder or for chronic serious mental illness, but how many people are staying in care, right? So follow-up care post-crisis, great, doors open, get them in, engagement. But what are we going to do with retention and care? How do you prioritize that as an intentional strategy, baking in peer and family involvement, of course, collaboration, trying to meet people where they're at, you know? Rowan, you're in distress. What do I need to think about? What do we need to do to partner together to get you? You have this goal, you read in the library every day. My God, that's amazing. I'd love to have a book club with her. Meet people where they're at. But we also need to look at data around what is happening. Like there's some really interesting studies looking at why people with methamphetamine don't stay in care, or why people who leave prison settings don't stay in care. Part of it is the cueing and the cravings. That's a biological phenomenon. So what are we doing to address those kinds of issues? You know, we've got lots of things to learn about people with trauma histories, how we address trauma in a different way. So engagement is going to be a key. This isn't going to work if we don't start building in engagement so that we stop people moving into the EDs, getting arrested out of care, and then moving into these settings where they're then waiting for other care. Trying to get ahead of this. Strategies for routinizing and developing effective technology. Technology is basically now everywhere. EHRs, we've got these self-help apps, information exchanges, we've got personal care strategies. You can go, I get this thing every day saying, did you do your meditation? Did you do your gratitude checks? Did you do your this? Did you do your that? Virtual therapies, which are great, on-demand supports, data analytics capabilities, systems coordination, and even artificial intelligence that will look through medical records and say who's going to be at suicide risk that we need to intervene with. We've got so much happening, it's amazing. But oh God, now what did I do? I don't know, I'm the technology thing, right? It's perfect timing. So what do? We need to expand technology, there's no doubt. It's expanding around us anyway, even if we didn't want to expand, even if some of us just wanted to go to the old-fashioned way. There's no way anymore. We're there. We're in this world of technology. And as one of my children says, it's the metaverse, Mom. We're going to go to the metaverse eventually, so just be prepared. I'm like, no, I'm not ready for the metaverse. Expand with enthusiasm. We have to embrace it. It's exciting. It is exciting. There's super great potential. But we have to be cautious. We know that people with serious depression or serious anxiety or serious psychosis are not going to only be helped by just a quick talk on 988, right? We need to build in evidence-based practices. We need to understand where these things are helpful, where they're not helpful. Yes, there's great data analytics. We can drive data in better ways and answer more questions. That's awesome. Information sharing is going to be available, but there's also privacy concerns. And so we have to think about what are going to be the regulations around which apps are effective. You know, insurance companies are now investing in these apps. If they are great at preventing other conditions downstream, fantastic. If they're not, are they doing what they say that they're going to do? And so we have to think about where is the data and evidence for the different technologies to make sure that they're going to be useful. Okay, old, new, and improved partnerships. We've got some great ones on the horizon, like 988 and 911. Like we haven't who knew what a PSAP was a few years ago? Like nobody knew what a PSAP was. Now everybody talks about PSAPs. We've got new partnerships that have emerged. Public health and behavioral health, COVID-19, hello. I'm the Commissioner of Mental Health. I'm the Commissioner of Public Health. Houston, we have a problem. COVID-19, we got to work together, right? New partnerships, it's amazing. We can't lose those. We have to keep forging them even if hopefully someday COVID wanes. Child welfare and children's behavioral health, I mean, those are partnerships that we know need to be strong. Criminal legal, juvenile justice, and behavioral health. The reason why you guys are getting so much Pinals today is because tomorrow I'm going to the Chief Justice Conference where they're doing a whole thing about the task force to improve people in court who have mental illness. And, you know, that's a partnership that's happening, but they need to have trust in the behavioral health system because right now they're frustrated and they're trying to solve it on their own and, you know, trying to build these bridges for partnerships so that they're not solving it on their own. We've got IDD and SMI coming together. We have, again, complex populations, waivers that will be broader to be able to address the needs of people who can't just be boxed into one diagnosis, family peer partners and state leaders, and lots more to come, faith-based partnerships, cultural partnerships. Like there's lots of ways that we can keep improving along those lines. And then not just sustainable services, but expandable services. We know that what the current demand is. When you build 988, the thinking, and I don't know where David Covington went, but if you listen to him, what is it? How many men? We're going to get calls and calls and calls, right, David? It's going to grow. We don't know, but we need to be available. We need to have sources and resources. And so we need to sustain services. We're getting a lot of money now. When the COVID-19 money goes away, maybe 10 years from now, 5 years from now, 3 years from now, I don't know. Are there going to be the same resources, and are we going to have the resources, again, to expand what we're doing as we try and build out these engagement strategies? None of this is new. None of this is, you know, sort of a discovery. This is all just distilling where you're all at and thinking about some of the priority areas that I think really need to be the focus of this year. Moving from crisis to care and thinking about care steps that are necessary. And it's really in line with what the Biden-Harris administration put forth in their agenda. So we've got attention on this. Now is the time. Strengthen system capacity, connect Americans to care, support Americans by creating healthy environments. It's all there, it's all baked into the plan, and now it's just, you know, the small task of the leaders to help drive these changes forward. So we're going to take steps now to help set the stage for tomorrow. State behavioral health authorities and their teams are well poised to take this on. And I really applaud all the work that you are doing and the work that I know you'll do in the days ahead, weeks and months and years.